she gave them a different state. When I interviewed, she had a PhD in, we think, in English literature. And when I interviewed her, she knew that she had been a college professor. She couldn't tell me what college or university she had taught at. She knew she had written and published papers, but she didn't know where or what they were about. So I mean, there's obviously like massive memory impairment, still in a day-to-day functional way, but still able to do very, very well on this. You can see other kinds of issues like that with people that are either highly intelligent or with a lot of education. There are both formulas and norms for doing age and education corrections. Some of them get a little tricky. I remember Diana Chu pointing out once that if you did the education correction on anybody with a PhD or an MD, a score of 30 on the Folstein would mean that you were admitted. Seems sort of unfortunate. So it's not, it's not perfect to do it. The concentration thing, the serial sevens thing, has always bothered me as a mental status task, because if a young person screws it up, you tend to interpret it as their concentration is disrupted by anxiety or depression. Unless you're the psychiatric inpatient unit, in which case you might interpret it as their concentration is disrupted by schizophrenia. If an older person makes the same mistake, it's dementia. And this is not actually uncommon with the way that different mental status exam traditions and even neuropsych tests get interpreted differently depending on context. Joe?
Based on the discussion so far, it seems like in order to really diagnose dementia, or in the way that we're talking about it as a decline, that you need 2 points in time. Is that right, first off?
In principle, yes. People very rarely do that, but that's one of the ways that you can get around the intelligence issues and high education kind of issues and the whole kind of definition thing. Is you would be much more sure if you saw a steady decline, and if you were trying to diagnose somebody who's very intelligent or highly educated, you'd probably want a more sophisticated assessment. So you'd use more like neuropsych testing, and then you'd want to see some decline over time.
Now, is that a unique psychological, like in terms of psychological conditions, is that a unique thing? In order, like you say, in principle, you really need 2 points in time, because when I think of like other things, I don't really see that,
Yeah, well, it would be unusual. I'm not sure it's unique, but certainly unusual. You wouldn't normally think that you would need more than one time for diagnosis. I mean, you might reassess somebody over the course of treatment, for example, to see if people are moving out of diagnosis, but you would make a diagnosis based on a single assessment. Which is probably the reason that we try to do it all the time with dementia, whether it's appropriate or not. The Folstein and some of the other many mental tests have been translated into a lot of languages. It's been revalidated against psychiatric diagnosis anyway, or neurologist diagnosis in some of those languages, but not all of them. I've never seen a study, and when I've brought this up with people that I think that know the literature on that better than I would, they've not told me of ones here. In English, it's been validated against brain pathology. I don't know that it's ever been validated against brain pathology in other languages. And the translation alone doesn't really get it, because some of these things don't make any sense. There's no, you can't translate the sentence no ifs, ands, or buts in a way that, one, makes sense to anybody in another language, and two, that preserves the actual test is whether you get the final S on there or not. And so even if you can say it in another language, it usually comes out meaning nothing whatsoever in another language. You don't always get the S sound. People have pointed out that the words to be remembered will not necessarily have the same number of syllables or the same frequency of familiarity in other languages. There are cultural arguments that there certainly are, at least in villages in some other countries, there are societies and cultures where knowing today's date or even like knowing your own birth date and age are totally unimportant culturally. And so it might not be the same test. One of my favorite examples is when a group at UCLA and the University of Puerto Rico was developing a Puerto Rican Spanish version of this. They pointed out that in Puerto Rico, a perfectly acceptable range of answers to the question what season this is wet, dry, Christmas, and Easter. I'm always wondering, in Southern California, should somebody be counted off if you ask them what season it is and they say fire? All that said, it's the most common use, and in some ways, it's actually, there are lots of meta-analyses that show that it's very good at detecting moderate to more severe dementia. Within that age range of people with, say, more than 8 or less than 16 years of education. And less good at probably the early stages. It seems to actually hold up pretty well across cultures and languages with appropriate adaptations. But particularly if you have any reason to suspect vocal damage or the pattern of what you're seeing doesn't look a lot like Alzheimer's disease, you probably want a more complete neuropsychological assessment. Certainly at this stage, if early diagnosis or catching early Alzheimer's is important to you, you would need a more sophisticated diagnosis. And without repeated testing, you may still not know a whole lot. A lot of the neuropsych rules are actually pretty conservative before they diagnose somebody as having impairment. And it's an interesting question. With any diagnostic rule, you tend to be weighting yourself towards either a higher risk of a false positive or a higher risk of a false negative. And are you more worried about telling somebody that they have dementia when they don't have it? Or are you more worried about telling somebody that they're okay when they do have it? And I started off my professional career very concerned about the first. I thought that the most damage would be telling people that they had dementia when they didn't have it. And one of the things I've learned over the course of my career from working with people over longer periods of time and living in a small community where your mistakes come back to haunt you is that there is damage on the other side too. And we see people not infrequently frustrated with when they know something's going wrong with their mind and people are telling them that they're okay. And even more so, family members as they're trying to wrestle with what to do and what plans to make. So diagnosticians too of all stripes can be very reluctant to diagnose dementia, even when there is some fairly clear evidence of either real life deficits or some neuropsych deficits, but maybe not getting to the level that the local rules and policies dictate. We had a case in our older adult center at Escape several years back where I was involved because I was supervising the student who was sitting behind the concussion, and he had actually been through I guess I'll catch a little bit, it's like a good neuropsych workup